It's great to see you all today. Welcome to another edition of Virtual Morning Report. I see that we already have a case volunteer. Excellent, Drew. Thank you so much. Welcome everybody. Thank you all for joining us on this Monday afternoon. For those of you who I haven't had the chance to meet virtually yet or in person, my name's Jack. I'm an internal medicine resident here in San Francisco, and I'm lucky enough to get to be joining you all with my good friend Dan Minter today, who's going to be one of the co-facilitators with us on this lovely afternoon or late evening or morning, depending on where you are. I'm seeing lots of familiar faces who are joining us here in the gallery view. As always, we will solicit volunteers for both a case, which we have with Drew, and then also 2 volunteers to come and join us in the lukewarm seat to co-discuss today. As always, as we seek to promote gender parity across the clinical reasoning space, we would love to have at least one of the facilitators be somebody who does not identify as a man, as men have traditionally occupied the spaces of the discussants in these clinical problem-solving exercises. And so we are looking for 2 volunteers for somebody to discuss with us. And as we just mentioned, at least one of those volunteers would hopefully be somebody who does not identify as a man. Yes, Uncle Bob, I'm with you. Not only do we get to have VMR and NCAA basketball, but for those of you who are fans of basketball and watching either in the United States or across the world, we thank you dearly for putting March Madness on pause to join us this evening for some extra learning. Preeti, thank you so much for also volunteering. I think we have Drew, who has already volunteered to present a case today, but if you're able to maybe save it for another VMR this week, we would love to have you discuss. I know that I'm really looking forward to your case after our brief email exchange. But yes, let's see. I will maybe reflect briefly off of some interesting teaching points from yesterday's student VMR case as we wait for volunteers to step up to discuss in the chat. Yesterday was actually a very fascinating case of a young woman who presented with nonspecific inflammatory symptoms for a little bit over a month, and then was found to have some pretty interesting findings on imaging that included airspace opacities, pleural effusions, and then also a rapidly developing new large pericardial effusion with impending tamponade. And for those of you who may have heard our recent space learning series episode, you know how much I love pericardial tamponade and the pathophysiology of large pleural effusions. And I think that there's potentially a couple useful teaching points to go over here as we talk about pericardial effusions. One of them being sort of the ways in which we can start to see the symptom development in a pericardial effusion, and then also the ways in which the rate of accumulation can also impact the severity of the clinical presentation, and then can maybe talk briefly about making the formal diagnosis of pericardial tamponade. And so if we zoom out and think about what the ultimate problem is with rapidly developing pericardial effusions or any pericardial effusions that cause hemodynamic problems, it's really that what we end up having is that we basically blood flow through the pump system of the body, through the heart, starts to stop. And the reason that it starts to stop is because the pressure that the effusion is exerting on the outside of the cardiac wall will lead to a delay in the filling of the right side of the heart, which leads to a which leads to a slowing of the output from the right side of the heart, a slowing in the filling of the left side of the heart, and then a decrease in the cardiac output from the left side of the heart. And so ultimately, you start to basically get blood flow stopping, and the pump system is starting to fail. It's not quite the same as the pump system starting to fail in cardiogenic shock, because while the pump is still working, the pump just isn't allowed to fill with water. Now, our bodies are adapting machines. And so oftentimes when the onset of pathology is slow, we are able to adapt and accommodate over time. And so you may see patients who, for example, have longstanding malignancy who have very, very large pericardial effusions, but are really minimally symptomatic from those because they have had time to adapt their hemodynamics to allow the effusion to exist there without significant compromise. But when the effusion develops quickly and we have an abrupt change in the pressures existing outside the heart, we can then have an abrupt change in the filling of the right and the left side of the heart, which can lead to an abrupt change in hemodynamics. And so this patient really had a double danger in terms of their pericardial effusion. They not only had a rapidly accumulating pericardial effusion, but they also had a rapidly accumulating large pericardial effusion. And those two things together can create a very aggressive and very abrupt hemodynamic compromise. And if we think a little bit about what exactly that, or I guess how exactly we diagnose that hemodynamic compromise, many of us have maybe heard of the phrase pulsus paradoxus as one of the physical exam findings that we can use to diagnose pericardial tamponade. Pulsus paradoxus, I think, is actually a misnomer, and it makes the pathophysiology not make sense very well. Because all of us, when we exist here at our baseline, have a mild finding of pulsus paradoxus. And when you have pericardial tamponade, that finding just gets exaggerated because of the presence of the pericardial effusion. So what is pulsus paradoxus? Pulsus paradoxus is a fall in blood pressure that happens with inspiration because of changes in the filling of the different sides of the heart with inspiration. And so normally, if I take a deep breath in, I will have an increase in venous return to the right side of the heart because the negative pressure in my chest leads to increased filling of the right side of my heart. Under normal circumstances, my RV free wall will expand to accommodate that increase in venous return, and my septum will bulge maybe just a little bit into the left side of my heart. And those two things together accommodate the increased venous return. That septal bulge will obstruct a small amount of flow into the left side of the heart that's happening simultaneously. And then my left-sided stroke volume will fall just a little bit because that septum bulges. And so I will have a decrease in blood pressure that happens when I take a breath in. That's under normal circumstances. This is normally barely detectable, but it does exist. When we inspire, our blood pressure falls just a little bit. Now, if you have pericardial tamponade and you have a big piece of pressure on the outside of that RV free wall, that RV free wall can't expand anymore. And so in the setting of impending tamponade, when you take a deep breath in, that septal bulge is what is responsible for accommodating the increase in venous return. And the more that septum bulges into the left side of the heart, the more you're going to have a decrease in filling of the left side of the heart. And the more you're going to have a drop in blood pressure when you take a deep breath in because your left-sided stroke volume falls dramatically. And so again, the septal bulge that happens under pericardial tamponade and the decrease in left-sided filling is not paradoxical under the setting of tamponade. It is just exaggerated in the setting of tamponade. And so a large pericardial effusion will lead to an exaggerated septal bulge, which leads to a significant fall in the blood pressure. And then if that fall in blood pressure is more than 10 or more than, Dan, remind me, more than 10 or more than 20? I'm blanking today because I'm doing math in public. More than 10, thank you. If it is more than 10, then we can call it signs of pericardial tamponade. But pulsus paradoxus, it's not paradoxical at all. It's just an exaggerated physiologic response that exists because the RV free wall can no longer expand anymore. I've run out of real estate here, but to summarize, there's two things that matter when we talk about pericardial effusions. One is the size of the effusion, and two is the rate of accumulation. The larger the effusion and the faster it accumulates, the higher the risk of tamponade. Effusions that accumulate slowly, we're more likely to be able to adapt to the hemodynamic changes that the effusion brings on. But when it happens quickly, we don't have time to adapt. And so a rapidly accumulating effusion is more likely to cause significant hemodynamic problems. Those hemodynamic problems develop because the effusion impacts the RV free wall's ability to accommodate increased venous return. And then the septum and thus the left side chambers of the heart are what get compromised. And so pulsus paradoxus is not paradoxical at all. It is just an exaggerated response or an exaggerated response to the increased venous return to the right side of the heart.
And for everybody out there, look in the chat. I just put Jack's amazing tutorial on pulsus exaggeratus. It's basically a Jack Penner staple at this point. So if you have a free chance to take a peek there in the chat. Jack, it does seem like we have Mario who has volunteered, and then Thiago has volunteered, but is graciously deferring if anybody new wants to step into the role of discussant. But Mario, why don't you take a second and introduce yourself to those who may not know you from VMR?
Yes, of course. Hi, everyone. My name is Mario. I'm a medical student from Lima, Peru. I've been joining VMR, I think, from the first day. And I've discussed Mondays, I think, I think last week or maybe a couple of weeks ago. So just really excited to be here and discuss new interesting cases. Always learn a lot.
Awesome. Thank you so much, Mario. And then Jack, it looks like both Thiago and Sonia have volunteered in the chat. Is that correct?
Awesome. I think so, yeah. Let's see, maybe for the sake of what we had mentioned at the beginning, thank you, Thiago. Sonia, why don't we have you go ahead and introduce yourself here? And Thiago, thank you for graciously giving Sonia the opportunity to step into the lukewarm seat.
Oh, wow. Hi. Thank you, Thiago. I highly encourage anybody who hasn't done this before to step into said lukewarm seat next time. It's super fun. As I can attest, I'm only pretending to be still in general medicine, but love it to death. I'm actually a room fellow here in DC, and happy to be here.
Awesome. Sonia, what part of DC are you in? I was there for 4 years during medical school. I have very fond memories of the city.
DC proper. I live in Maryland, but it's easier to say I'm from DC.
Oh, nice. Are you nice? What area in Maryland? Are you up in Bethesda area?
Kind of. I'm in Kensington, so I'm like right by where 270 splits off from the Beltway.
Yeah. Oh, that's awesome.
Very nice commute down Connecticut.
Yes. Awesome. Well, thank you. Thank you so much. And then lastly, why don't we turn it over to you, Drew, someone who needs no introduction, but we're thrilled to have you presenting a case today.
Okay, maybe a little bit of a reintroduction, yes, since there have been multiple changes since the last time I presented on VMR. So, hi everyone, I'm Drew. I am a PGY 0 now at Western Michigan University in Med Peds, and about to be MD graduate from Virginia Commonwealth University School of Medicine, MCV for all the old timers. And this was a case of a patient that I had taken care of throughout my time on endocrine consults, which is my last clinical rotation. So I just signed off on this patient a couple of days ago. And I am so glad that that Sama Nematolahi, the great TXID Edu on Twitter, is here, because he is going to love this case. It's an infectious, I'll already put it out there that it's an infectious disease kind of case. So.
Well, this sounds very exciting. Sonia, why don't you and I team up as the Beltway superheroes today, and we can take the first aliquot, and then we can let Dan and Mario take the second aliquot.
Sorry, you drew the short straw, Mario. I apologize.
No, it's not the short straw. All right. So, all right. Chief concern for this patient. Hyperthermia. Let's just say that much. And I'm going to stop it right there. I want to get some thoughts from you guys.
All right. So we have an elevated temperature. Sonia, that is all the information we have to work with, and I'm going to let you take it away here.
So I think often I translate hyperthermia into fever, but Drew's wording of it as hyperthermia in particular makes me think that perhaps I ought not to just be thinking of this as fever. Generally speaking, I also think of hyperthermia in the same way that I think about inflammation and those terrible systemic, non-specific inflammatory symptoms. So I break it down into the IMAID mnemonic. And I think about infection certainly being, infection certainly being up there as one of the most common causes of inflammation and probably hyperthermia. But also malignancy and autoimmune disease. And then drugs and endocrine kind of jump to the forefront, just knowing the background of this patient being on an endocrine service and thinking about how hyperthermia can be reactive as much as it is a primary process makes me think about the endocrine etiologies a little bit more as well.
I think your analysis is absolutely phenomenal, and I agree with you. I think my reflection alongside you is also the ways in which the wording that we get can so often shift us in a case where in reality we may just see a number on a patient's vital signs. But if it's called fever, we go down one route, and if it's called hyperthermia, we go down another route. And I love the way that you slice the elevated temperature here. We can sort of go down the fever pathway and think about all of the inflammatory diseases that might exist in our IMAID mnemonic, and then we can also think about maybe some of the things that are expanding beyond fever into merely an elevated temperature, and that could be due to things like environmental factors, like are we dealing with heat stroke? It could be things related to drugs that we may have taken that may be altering temperature set points in the brain, whether it's something like neuroleptic malignant syndrome or something like serotonin syndrome or something like increased sympathetic tone that we may see with the withdrawal of certain medications. And then I love where you took it at the end there, thinking about also, if we think about sympathetic tone can not only come from the withdrawal of certain medications like benzodiazepine withdrawal or alcohol withdrawal or baclofen withdrawal, but it can also come from increased sympathetic tone. And we can look at the hypothalamic pituitary, thyroid, and adrenal axis as places in which that sympathetic tone could potentially be triggered, whether it's due to a central mediated process that's leading to elevated activation of the adrenergic pathway, or a more peripheral process that's related to either increased thyroid activity, or potentially increased adrenal output or increased catecholamine output, like we might see with something like a pheochromocytoma. But in reality, we're going to take this differential diagnosis that we just laid out, and we're going to prioritize it, thinking about both the base rate of disease and also the signature of the disease that we might see in the HPI. More often than not, an elevated temperature is going to be related to exactly what you said, the sort of fever algorithm, but we may see certain things early on that push us away from our fever high temperature into true hyperthermia. And some of the things that I think about there is, one, the potential physical exam findings that we might see, like if the patient is rigid, or the actual degree of temperature rise. And if temperatures are starting to get, fevers up into the 40s, when fevers get that high, rather than prioritizing fever far above the sort of non-febrile causes of an elevated temperature, when we start to get a temperature up into the 40s, the gap in the probabilities between those two diseases starts to narrow, and we can start to think about these hyperthermic diseases right alongside the febrile diseases. And so similarly to what we were talking about with the pericardial effusion in terms of the size of the effusion and the rate of the accumulation, I think the size of the high temperature today, or the magnitude of the high temperature, can help us potentially prioritize which part of that diagnostic schema for a high temperature we go down.
I knew it was a good decision to only start with one word as the chief concern for this patient, because that was an amazing amount of discussion that we were able to have just on that one little bit. Now, bear with me, because this case is going to involve a pretty extensive hospital course and a little bit of jumping, and I am working off of an EMR here, so again, forgive me. So this is a 20-year-old gentleman, autistic gentleman, who also has a history of seizure disorder as well, who initially presented for nausea, vomiting, and decreased appetite over the past 2 days. and had also been coughing for several days in addition to having watery diarrhea. And on arrival to the ED, he was hemodynamically stable, but he was noted to be hypoxic on room air, and was also found to be COVID positive. He, in his state, being in an unfamiliar environment, became agitated, required sedation with Haldol, Ativan, and Benadryl. There was an inability to establish IV access and continued pulse ox monitoring. And so a decision was made to intubate the patient essentially for safety rather than for hypoxia, which is an unfortunate case for this patient. But that was essentially the rationale for this patient being admitted. And now let me get to when this patient actually started fevering. This was about 5 or so days into the admission. He started having high temperatures. He got febrile up to about 38.5. And by this time he was admitted to the pediatric ICU, where there was a little bit of a shortage, so he would have ordinarily been admitted to the MRICU here at MCV, but he got admitted to the pediatric side. So febrile, and he febrile, intubated, and so essentially what we were trying to figure out is what exactly is the fever cause. I think with that, is it okay if I go into the southwest corner, or do we want to stop here? Okay, I'll move on to the southwest corner then. So, in terms of medications, past history. So he is autistic, as I had mentioned before. He also has ADHD. He has he is class 3 obesity and intractable generalized tonic-clonic epilepsy that's currently controlled on medication. And he has an extensive list of medications that he was on when he was admitted. Let me see if I can find them real quick. All right. So on admission, he was on Adderall, clobazam, clonazepam, haloperidol, lamotrigine, lorazepam, olanzapine, trazodone, and valproic acid. The patient was also given remdesivir and dexamethasone as per the COVID protocol here. In terms of family history, nothing of note. In terms of his social history, he lives with his father and sister, and both of them came down with COVID as well. And in terms of health-related behaviors, nothing of note. No tobacco, no alcohol, no other drugs in use. And in terms of allergies, nothing known. And I will leave it there for now.
And sorry, Drew, just because so much of like the approach to fever, especially in an ICU patient, when they develop fever in the hospital, focuses on stuff that's happened. Do you mind just, was his admission just that he got intubated for this, personal protection, got remdesivir, Dex, and then no fevers until day 5? Or was there anything else in the admission that's relevant?
It's essentially you have it.
Okay, and no new medications like lamotrigine's longstanding med that wasn't recently changed or anything?
Yeah, no, the only things that were new, let me just see real quick. Well, that's not it. Yeah, so, I think he was just on like they had started ceftriaxone antibiotics for him, and they had also started Lasix as well. And he is on and he was on Tomidine, fentanyl, and propofol and vecuronium to sedate him.
So he's paralyzed?
Yes.
Okay, awesome. Well, Mario, do you want to, there's a pretty meaty aliquot going from one word to a whole bunch of words and stuff. So we've got a lot to discuss here. What are your initial thoughts as you kind of parse through this case so far?
Well, I'm thinking about two main things. One is what happened, what's the chief complaint, why the patient came actually to the hospital, because like a cough, water diarrhea, and hypoxemia. I'm like, what is that, right? What's driving this patient's initial complaints? In terms of that, I would and the lack of. It seems that at the admission there was a lack of fever, right, Drew? There was no fever at admission.
No, there was not.
There was not.
Yeah, his temperature was normal at the time.
So with this COVID positive test, could this just be caused secondary to this COVID infection? Maybe. I would still be tracking that. Maybe something emerges from that. And the second thing is this development of what Drew has told us from the beginning, that's hyperthermia. And I think we have a good suspicion to call this hyperthermia, not fever, because of all the medications this patient has been, because of all the medication this patient was already and has received again. And one thing that comes to mind is drug-induced hyperthermia. I think of a couple of syndromes. One that occurs very rapid after usually sedation is a malignant neuroleptic syndrome. Usually occurs less than 24 hours after the initiation of the drugs. I think muscle relaxants are the cause, and also inhaled anesthetics. I think this patient has been exposed to some of these medications. And the other thing is the malignant hyperthermia. I think malignant hyperthermia even occurred prior, a lot sooner than that. So I think haloperidol is associated with malignant hyperthermic syndrome, I'm sorry, with neuroleptic malignant syndrome. And the other one is malignant hyperthermia. I think I'm getting those two confused, but I think those are two things I would keep track. And how to work that up, maybe just consider discontinuing some of the medications or pursuing further diagnostic tests. But those are my thoughts.
Mario, I love that. Yeah, I think one thing that you highlight that's really important is, that this patient came in, presumably without fever and then developed it in the hospital. So we're faced with this question of a fever potentially acquired in the hospital. And again, staying broad of, is it something that we've done personally for this patient in the form of a new medication? The other consideration is, common things being common, right? Like somebody in the ICU intubated, there's a whole swath of ICU associated infections that could be at play here. The only other, the other sort of dimension to this case that, Drew mentioned is, this patient came in with COVID, and then we always have to evaluate, it's like, is this truly, as it seems? And I would say, like, I have a pretty high concern for this, given that his family all had COVID, the nausea, vomiting, diarrhea, hypoxia, cough, that's a pretty compatible syndrome. So I think it's reasonable to assume that, yes, this patient had COVID. I wonder where in his course he was, right? Because people tend to have, if they're going to experience more severe disease, they'll tend to experience that around like day 7, day 8. So, is he just now manifesting from his COVID infection, or is it truly something superimposed that potentially is acquired here in the hospital? Mario, maybe you can help me brainstorm, like when you have somebody in the ICU, like what do you think like common infectious sources might be? And maybe we could create a list together that, we could investigate on exam and with radiology and stuff.
Well, I think the base rate makes you think of pneumonia, hospital acquired, or in this case, this patient is ventilator associated pneumonia.
Yeah.
I think an UTI, that's something I would also be considering. Maybe a skin and soft tissue infection, a bacteremia without an apparent source, like a hepatobiliary infection, and well, those would be the first thing I would look into.
Perfect. Yeah. I think that's a great list. And the only thing that I'll add on is a lot of these times, a lot of times patients are in the ICU, they often have like central lines or some other sort of venous access. So I look at go look at the patient, and like wherever there's something plugged into the patient, that's potentially a site of infection, right? So you're right, tube in their mouth, in their endotracheal tube, do they have a central line? Do they have a Foley catheter? Those are all highly suspicious. And then you brought up some really other great ones, like, acalculous cholecystitis in somebody who's critically ill in the ICU. I think you mentioned it earlier on too, but really paying a lot of attention to other ICU interventions like drugs. Like Precedex is a common cause of drug fever in patients in the ICU. And I love how you went through like the antipsychotics and brought up, NMS, malignant hyperthermia, I think is definitely a consideration, especially if, Drew hasn't told us that if this patient had inhaled anesthetic at all, but that would certainly be a concern there. And then, go in that realm too, thinking like serotonin syndrome, some of these other hyperthermic syndromes. But I think at this point, I would probably approach this as like fever in the ICU, trying to think of nosocomial infections with that list that you and I put together. The only other thought that I'll bring up before we hand it back to Drew and take it over to Jack is, this is a patient with COVID. Could they have a superimposed bacterial infection? And I know that we've got some ID superstars of Twitter fame in the audience and stuff. So, maybe I'll let them go wild in the chat, but, what I remember seeing is that I'm going to get the numbers wrong, but oftentimes patients with COVID are put on empiric antibiotics, something like more than half, I think it was like 60% get empiric antibiotics, but the actual rate of true bacterial co-infection is like vanishingly small, in like the single digits or less percentage. But that doesn't mean it can't happen, right? Especially somebody who's, sick otherwise. So certain things that you would think about is like a post-viral bacterial pneumonia. So, staph, strep, potentially, gram negatives that you would acquire in the ICU, or even, there's a growing literature on post-COVID aspergillus infection. I would say that's probably less likely in his case, because it seems like this is a pretty, he's only been here for 5 days, but I would, not take that necessarily off of our list quite yet. But anyway, to recap, from your amazing discussion, Mario's, let's start with fever in the ICU. Think of common things being common. Look at all the tubes plugged into our patient, and then also pay more than passing thought to his medication list. Anything else you'd like to add to that? Awesome. Well, let's turn it back over to Drew, and I'm excited to see where this case goes.
Yeah. So now we're going to jump several days because there was an extensive amount of workup that was done on this patient. But I am going to give you the day of the clincher lab examination. So vitals wise, temperature of 39.9 Celsius max. Blood pressure of 166 over 87. Heart rate of 128. Resp rate of 25. And of note, his set resp rate was 4, so he was overdriving the vent. And setting 92% on an FiO2 of 50%. And he also had a PEEP of 11 and pressure support of 12. So on general exam, this patient, so this is again a patient with class 3 obesity. He's was intubated at the time. Neck exam, nothing really of note. Well, head and neck exam, nothing really of note. Cardiovascular exam, tachycardic but regular rhythm, no murmurs, rubs, or gallops. And because of his habitus, his heart sounds are pretty distant. And at the time, there was no peripheral pitting edema, although he did develop it later. Respiratory-wise, lung sounds were distant, but there were no crackles or wheezing appreciated. And as I had mentioned before, he was over-breathing the vent. Abdominal exam, protuberant but soft, active bowel sounds, and unable to appreciate if it was tender or not. Extremities exam and skin exam, there was noted to be a pressure ulcer in the sacrum. And for his neuro exam, he is sedated and unresponsive. And I am going to leave it there for now.
Drew, how many days into his hospitalization is this now?
This is...
You just don't make a pressure ulcer super duper quick. So I imagine he's a while, right?
Yeah, this was well into his hospitalization, as I had said. This was about, I don't know, 3 to 4 weeks into his hospitalization.
All right, the plot continues to thicken here. Sonia, I would love to hear your thoughts on kind of some of the updated data that we have so far.
Well, I think that the thing that yells at me most loudly is the severity of that temperature elevation. I think we touched on it a little bit earlier, thinking about how the quality of a chief concern can help us to guide our differential one way or another. And I don't typically think of many things causing a temperature as high as 39.9, in other words, basically 40 degrees Celsius. So from my sort of fast thinking, not so slow brain, I go straight to my drug-induced hyperthermia differential, because NMS and serotonin syndrome are two of the things that I think of as causing a temperature this high. I also certainly think about environmental factors, but I think that usually some of the more common culprits of fever, as we talked about, fever from infection, whatever the source may be, either that ET tube or a sacral ulcer, skin breakdown, COVID, whatever it may be, I don't normally think of that as being quite as associated with quite so high a temperature elevation. And so I think that that's starting to push me even more down the pathway of elevated temperature from maybe not an inflammatory cause as we typically think of it. We already alluded to the medications being concerning for possible drug effects or even interactions, things that on a normal basis, this patient may have tolerated just fine once sort of precipitously thrown over the edge of a new medication added that alters the metabolism of different enzymes in the body and causes either higher levels than usual or lower levels than usual, is certainly ripe for the picking. But I think that I would probably prioritize what we've done to the patient and what has happened to him while he's been with us in the hospital, just because it's been so long into the hospital course. And I think that my first line of attack would be to think about the medications and what interactions would be most likely or most common. And then my next line of thinking would be, what could we have done or not done? In other words, what could we have missed and not treated that would have caused him to get so much sicker as he is? I think those are at least a few initial thoughts.
Yeah, so I completely agree with you. I love seeing the focus on kind of recognizing that there are potentially multiple curves of illness here. There is the curve of the illness that brought the patient into the hospital, and then there is also the curve of illness that can be associated by just being in the hospital. And when we have had a nosocomial exposure for up to 3 to 4 weeks now, it sounds like there are certainly a number of things that could happen to a patient that could be causing these high temperatures. And I think your focus again on the medications and the nosocomial infections is spot on. I will just talk briefly about kind of two pieces of the physical exam data that are jumping out to me as things that are potentially surprising and notable in a patient who is in the ICU and sedated like this. And so we've talked about one vital sign abnormality, which is the ongoing high fevers. There's a second vital sign abnormality that really jumps out, which is the degree of tachycardia. Now tachycardia in a patient who is critically ill in the ICU can exist for a number of different reasons. One, they can have a disease that is leaving them tachycardic, whether it's a systemic inflammatory response to an infection, a hemodynamic compromise to something like distributive shock or cardiogenic shock. They could develop a new cardiac a new hemodynamic insult, like in the form of a pulmonary embolism that can lead to the development of sinus tachycardia, or it could be related all to the underlying illness that brought them into the hospital. In this case, the patient's hypoxic respiratory failure from COVID pneumonia. However, oftentimes when we see patients who are tachycardic in the ICU due to an underlying systemic inflammatory response, their blood pressure is often on the lower end. That is one, due to the fact that the patients will oftentimes have a distributive physiology, whether it's from the infection that they had, the infection that they have gotten in the hospital, or some other inflammatory process that's happening, but also oftentimes because of the medications that we give them. Fentanyl is a medication that can lead to increased vasodilation and lower the blood pressure. Many of the sedatives that patients are on when they are intubated and sedated, like propofol, can lead to a low level pressure requirement, just because these medications then not only relax our central nervous system, but they also oftentimes relax our vascular tone. And so the degree of hypertension that we have here, as well as the degree of tachycardia in a patient who's on Precedex, which oftentimes lowers the heart rate, to me stands out because it makes me think about the fact that this patient may have increased sympathetic tone. You combine that with the fact that the patient is over breathing the vent to this degree, and it also makes me wonder if there is increased sympathetic tone happening here. Now, the last piece about the vent is a bit of is confounded by the fact that the patient had a respiratory illness that brought them into the hospital. And so we may not be able to give that a lot of diagnostic weight, because patients who have a pulmonary infection are oftentimes just tachypnic. 3 to 4 weeks, maybe longer than we expect for somebody to have underlying respiratory compromise from a respiratory infection. But COVID pneumonia, we know, can have tails of up to many weeks or even many months of respiratory failure. And so the tachypnea and overbreathing the vent alone probably doesn't carry a lot of diagnostic weight, but the combination of the tachypnea, tachycardia, despite medications that usually decrease our chronotropy, and combined with the fact that the patient is quite hypertensive makes me think about increased sympathetic tone. And then if we ask ourselves, well, gosh, what are the types of things that can cause increased sympathetic tone? The sad kicker to this is that it's all of the things that we've already been talking about. It's medication effects related to things like serotonin syndrome or neuroleptic malignant syndrome. It's also medication or toxin mediated processes like withdrawal. For example, I know that the patient looks like was taking clonazepam in the outpatient setting, and I don't necessarily see that they have things on their medication list now that would necessarily give them the GABA-mediated activity that they need to avoid withdrawal. But again, those things may have been given to the patient. For example, patients oftentimes may have sedation with as-needed doses of midazolam. And then the other thing is, again, Drew both mentioned this as sort of the context through which he was looking at this, but the fact that there also may be a problem with the endocrine axis. And many of these diagnoses are either diagnoses of exclusion in the form of medications, where we make a medication change and things get better, or they're diagnoses that require lab testing to make a diagnosis, like in the form of things related to the endocrine axis. And so I guess to sort of summarize where I think Sonia and I are coming to now is we are still thinking about infectious causes, but maybe not necessarily having those at the top of our differential now, because it sounds like the workup has maybe not been necessarily revealing yet, but we still have to prioritize them just based on their base rate. But then right next to the infectious diseases in the setting of the tachycardia, the hypertension, and the tachypnea, and somebody who otherwise may not be expected to have these vital signs, thinking about things related to the sympathetic axis, and whether that's related to exogenous things like medications or endogenous things like the endocrine axis. And I think we could look for things like, again, like the thyroid axis or the adrenal axis as the first place to start.
All right. So again, bear with me because there were some interesting questions in the chat where there was a whole bunch of things about like did this patient have hyperglycemia? Does this patient have thyroid labs that are indicative of thyroid storm? I will tell you that his thyroid labs, and let me see if I can actually find them.
And Drew, I'm just looking at the time here. Maybe you can give us all of the lab data or all of the data that we need to make the final diagnosis, and then we can kick it over to Dan and Mario for the final diagnosis here, just so we don't go over by too much.
Okay, sure. Okay, so in terms of his TSH and free T4, his TSH was 2.5, his free T4 was 0.5. And his glucoses ranged, they were in the 200s at this time. As for other labs, sodium was in the 150s. Potassium was 4.6. Chloride was 110. Bicarb was 33. BUN of 62. Creatinine of 1.31. Calcium was in like the 8 range. And the CK that they got was in the 1100 range or so, which is high. And CRP of 8.6, lactate of 1.1. In terms of his CBC, his white count was 11. His hemoglobin was 8.4 with an MCV of 95.1. And his platelet count was 229. And the diff on the white count was 61% neutrophils, 27% lymphocytes, 10.7% monocytes, and 0.5% each of eosinophils and basophils. And his ESR was 46, which is high. And so there was a lot of imaging that got done prior to the final test. They got a CT chest with contrast, given that he had a fever of unknown source with COVID pneumonia. And it showed right lower lobe dense consolidation and a left lower lobe consolidation as well. Subtle bilateral ground glass opacities in the bilateral lungs. And I think we will leave it there because the diagnostic clincher is in the final test.
Sorry, Drew, I think it broke up for a second for me. You said bilateral GGOs was all they called on that?
Yes. Yep, bilateral GGOs.
Okay. Sorry, my internet's a little bit shaky. Well, Mario, this is a gargantuan challenge to see if we can stick the landing from here. But anything sticking out to you at this point? Where's your mind at right now?
Well, I think we're confirmed that there is an inflammatory process with an elevated ESR, but the thing that really caught my attention is the high CK. I think one thing that was, at least for me, missing, or I would have liked to maybe see in the exam is how was the muscle tone in this patient, because many of these drug-induced hyperthermias actually manifest with some type of rigidity or increased muscle tone. So I think this elevated CK makes me think there's some muscle issue going on here, and I think something we were talking initially, neuroleptic malignant syndrome usually present with increased muscle tone, and you can even have rhabdomyolysis, and that would explain also the increased BUN and creatinine. That's something what will be going through my mind. I still believe there's two things going on here. The consolidations. I think I would attribute that to the initial complaint. And I think I would be tracking that as COVID induced. And I remember that the COVID CT manifestations are usually subpleural, bilateral ground glass opacities. I'm not sure. Maybe this looks more like a lobar consolidation. I'm not sure. But the fact that this bilateral makes me think more of the thing I was thinking initially. So besides that, I'm not sure how we could make any progress except maybe tracking the meds and maybe giving this. Maybe I'm not sure if there's a diagnostic test for these drug-induced hyperthermias. I'm not sure. Maybe it's just like a trial of treatment. I'm not sure, but those are my thoughts.
Awesome. Thank you so much, Mario. I love the way you're sort of like picking up on signal here in the various laboratory abnormalities. I'll put it in the chat, but there's this great, basically, Drew, you can confirm that this is weeks and weeks of unremitting fever. Is that correct at this point?
Yes. Yeah, it's been about 3
Okay. Yeah, so
unremitting fevers.
Okay. Yeah. So, we're moving, I think, rapidly towards this, clinical syndrome of fever of unknown origin, which has variable definitions, but more or less it's like 3 weeks of fever is just that still remains unexplained despite, the very thorough workup whether that's inpatient or outpatient. And, there's this great article in the New England Journal. It's a perspective piece called Fever of Unknown Origin or Fever of Too Many Origins, where they lament, this once, storied sort of consult question of fever of unknown origin and how it's really changed the age of ICU medicine, where, you have like 10 lines going into this patient. They're on like a list of 20 different medications. They have, months long hospitalizations, and really it's moving away from, what historical descriptions of fever of unknown origin were to, much more iatrogenic sort of causes. So if you start with fever of unknown origin, the big buckets in like the papers from like the 1960s were infections, often atypical infections like tuberculosis, connective tissue diseases, and malignancy were kind of the three big buckets, but we're not necessarily in that scenario right now. So I think this fever of unknown origin or fever of too many origins in the ICU, we have to basically, kind of reset our frame and think more about stuff that could have been in the ICU, that could have been iatrogenic in terms of, what we're giving to the patient. I love how you're picking up on, like the medication element, Mario. In that CK and asking, was there elevated tone? I wonder if this patient has still been on neuromuscular blockade this entire time, and if that changes how we really interpret that CK elevation. I will say, as I scour the limited clinical data from this weeks-long hospitalization, the thing that probably stands out most to me, as it did to you, Mario, is the lobar consolidation. Sorry, my internet's kind of shaky. I apologize. But you're right that I don't think that lobar consolidation is something that's particularly, common in COVID. So I would wonder if the diagnostic test is ultimately going to be a bronchoscopy, looking at whatever's going on there in the lung, to see if there's maybe perhaps a superimposed infection. The things I would think of is, gram positives like staph, strep, gram negatives like enterogram negatives that you might see with ventilator associated pneumonia like Pseudomonas, E. coli, Klebsiella, some weirder ones like Stenotrophomonas, and then also this represent like this entity that we talked about with post infectious or post COVID Aspergillus infection, and thinking perhaps this patient may have altered local immunity with the dexamethasone that he's been on. So, that's if I guess right now of what the test is going to be, I think it's going to be a bronchoscopy. I'm recognizing that we're kind of shooting in the dark, and these cases just can be so tough because there's so many avenues to explore. And, more like not, the longer this goes on, the more likely it is to be something that we've done to the patient. So maybe I'll leave it there.
All right.
I'm not sure how that you guys got. My internet was kind of flipping out.
I got most of it. Yeah, and to answer Salman's question in the chat, he's been on pretty much everything. Ceftriaxone and azithromycin. He's been on Vanc. He's been on, I think he's been on Zosyn. He was on Flagyl at one point. Okay, actually, yeah, ceftriaxone, azithromycin. He was on cefepime, levoflox, Zosyn, Vanc, Flagyl, estrianam, and ceftaroline. Oh, actually, whoops, can't say that last one because it'll give away the answer, or one of the answers for the BAL. Yeah. So, yeah. So for the BAL, that was cultured, and it eventually revealed two things. And yes, Kushal, Lord have mercy, but that was only one of them. The other thing that they found, and let me see where they actually called it. Oh, they did a plotelia on the BAL. That turned positive. So he had two things: superimposed MRSA pneumonia and COVID-associated pulmonary aspergillosis. And that's the final diagnosis for him. He was started on liposomal amphotericin, changed to isobuconazole, and his fevers, he defervesced.
Okay, Struve. Jack, do you and Sonia want to reflect first?
Sure. Yeah, Sonia. Go ahead. Yeah. Any reflections on this case here?
Oh, I think that retrospect and in thinking back, the one thing that I kept thinking was it's probably less likely infection, because in my mind, what infections cause a fever to this degree? And so I almost tucked myself out of this diagnosis, which we even had said we have to prioritize because of its base rate, or at least it's a category of diagnoses. I'll put it that way. So I think this is another learning moment for me to remember that all of those wicked, terrible infections for the things that ought to be symbiotic, but sometimes are more problematic than not, are very much within the realm of possibility, even with a strange presentation that we think of as more in line with those textbook knee-jerk, got to rule out the drug etiologies and the endocrine etiologies. So I got to remember and respect the MRSA.
Yeah, absolutely. No, I think similar reflections coming to mind for me. I think one of the things that is jumping out at me is just how we try to replicate the authentic clinical setting in cases like this, and we never really get to fully step into what it's like to care for these patients. And I think one of the advantages to learning in a case conference setting is that oftentimes a lot of the noise of the clinical environment and a lot of the challenges to making an accurate diagnosis in the clinical environment, like the long time course over which these cases can play out, we get to circumvent those things in a case setting and sort of rapidly go through the data here and practice forming our schemas and our illness scripts. And the disadvantage of that is that it decontextualizes us from the environment in which reasoning is happening. And I think, right, if we were to anchor ourselves in the ICU talking about this patient on rounds every day, I would imagine that every single day we would still be thinking about an infection, because when you're in the hospital and somebody's temperature is high, you're thinking about infection over and over and over again. And the other thing is that in reality, we oftentimes are pursuing two diagnostic algorithms simultaneously, whereas here in a case like this, we oftentimes can only articulate one diagnostic pathway as we reason through a case. And so we oftentimes do feel compelled to put our nickel down, even if there's not a place even if there's not a place where we can really put our nickel down yet. And so I think one of the things that I'm struck by here is sort of the ways in which we were moving towards, exactly as you said, a non-infectious source because of, for me, many factors. This is a case that we know is being presented on a case conference, and so maybe it is a rare diagnosis. We also don't have a lot of the contextual data of seeing the fevers play out over time that we might have in the clinical environment. And I think a lot of those different environmental features can influence the way that we reason through a case. And I think certainly for me going forward, it's reminding me to sort of not just sit here and think about a case as though I'm looking at a whiteboard, but to try to situate myself on the ICU team on rounds every day, talking about this patient. And if I think back, if I had approached it from this conversation, I don't know if I would have been able to ever let infection out of my head, even if we brought all of these other potential diagnoses as causes of hyperthermia into our heads. What about you, Dan and Mario? Any thoughts before we kick it over to Rafa for teaching points? Exactly. Speechless.
Yeah.
All right, Rafa, take us home with some teaching points. Drew, thank you again for such a great case.
Thank you, Drew, for the case, like awesome case. Thank you, Mario. Thank you, Sonia, for discussing, and thank you, Jack and Dan, for taking your time to be with us. So we had a young male patient with fever. And when it comes to fever, we always talk here on Silvers about the pneumonic infection, malignancy, autoimmune drug, endocrinopathies. But also we have to think about other causes, like for example, environmental factors can come to play, like from a heat stroke. And when it comes to fever, Rabbi always teaches us to think about 4 questions. Who is this patient? Like, for example, is this patient with any congenital or acquired immunodeficiency? What, which is the clinical syndrome? When, which is the time course? And where, the epidemiological factors that this patient may be exposed to. And then we talked a little bit about drug-induced hyperthermia. There are many causes, including malignant neuroleptic syndrome, seen with muscle relaxants like succinylcholine, and inhaled anesthetics, that leads to hypothermia and severe muscle contractions, and the treatment is dantrolene, and also neuroleptic malignant syndrome seen with antipsychotics like haloperidol, that leads to muscle rigidity with the lead pipe. Also, dantrolene is the treatment. And then finally, serotonin syndrome that includes with increased clonus, hyperreflexia, hypertonia, tremors, seizures, and it's seen with antidepressants like SSRIs and SNRIs, and the treatment is cyproheptadine. And then remember to think about hospital-acquired infections like ventilator-associated pneumonia, UTI, surgical site-related infection, hepatobiliary infection, and central access infections. And there are many bugs involved, including Enterococcus, Staph aureus, which was the case, Staph epidermidis, Klebsiella, Aspergillus COVID, which was also the case, and I didn't know about that, and then Pseudomonas. And then when it comes to tachycardia, Jack reminded to think about sinus or pathological tachycardia. And a good way to differentiate both is the ECG. And you can see that in the setting of systemic inflammatory response or response to shock, for example, hypovolemic, obstructive, and distributive shock, unless it's, of course, cardiogenic shock or neurogenic shock as well. And when it comes to the increased sympathetic tone, it was a clue because this patient had hypertension, even with clonidine, and increased respiratory rate. And we tried to narrowing our diagnosis, including things like drug use and withdrawal, but also endocrinopathies like hypothyroidism and hypercortisolism. So thank you, everyone. I hope everyone had a good time, and I hope to see everyone tomorrow.
Hey guys.
See y'all later.